Hi, I'm Christine Coe, and I'll go over these 14 slides. So first off, we have this lesion with the tumor down here in the dermis, and it does look like a tumor. And when we start to zoom in, we see that there are quite a few giant cells, cells with numerous nuclei, and the nuclei look exactly like the nuclei of many of the other cells that only have single nuclei, and they look like histiocytes with a lot of sort of pink-purple cytoplasm. So these giant cells are osteoclastic giant cells, and this tumor is very well circumscribed, and it's compatible with a giant cell tumor of the tendon sheath. And this tumor often does have a fair amount of hemorrhage and even hemosiderin in lesions that are older. So that's giant cell tumor of the tendon sheath. Now we're going on to the next slide that you had in this series. And if I flip it around, we see that there's something in the dermis that's quite cellular. And as we zoom in, we start to see that what's cellular in the dermis are these spindle cells, so elongated nuclei, and they seem to be in fascicles. So with the axis of the cells running sideways or parallel, as well as they're cut in cross-section with just showing circles of nuclei, and the bundles are coming straight at you in and out. And so when we look at those cells, there's a perinuclear vacuole, and also in the cells that are cut longitudinally, there are also some perinuclear vacuoles, and these cells are quite cellular. There's too many of them, and they're hyperchromatic and pleomorphic. Mitoses I found were difficult to come by, but this degree of pleomorphism and cytologic atypia is concerning. And when we zoom back out, we can see that not only is this tumor located all the way up close to the epidermis, but it extends quite deeply. And here's some fat, and so it seems to extend down to the base of the biopsy into the subcutis as well. So this is quite concerning for a leiomyosarcoma, and presumably there is deeper involvement here. So subcutaneous leiomyosarcoma is much more concerning than pure dermal leiomyosarcoma. And important to note that if this tumor was located in the dermis alone, some don't consider that a true leiomyosarcoma and would consider calling it an atypical leiomyoma or a symplastic leiomyoma. Moving on to the next slide, you had this, and again, if I orient it so it's turned a little bit and begin to zoom in, we see that right here, the action is here in the middermis, and there's a palisade of histiocytes with some perivascular lymphocytic inflammation as well. And the palisade of histiocytes looks like it's arranged around light blue material, which is compatible with mucin. So this is granuloma annulare. And then we're going to move on now to the next slide. And this one, if I reorient this one, this is quite cellular, and there's not much going on in the epidermis, although it looks a little bit thickened. And we start to notice that there's this sort of brownish material in here with what looks like a lot of histiocytes, so granulomatous inflammation. So if we zoom in a little bit more and look at what this brown stuff is, which caught my eye at low power, we see there are lots and lots of circular brown structures that don't belong there in the dermis among the histiocytic or granulomatous inflammation. So round forms like this are called medlar bodies or sclerotic bodies or hot cross buns, and this is compatible with chromoblastomycosis. Next slide. This one also looks like there's a little bit of palisading of histiocytes around material that when we zoom in, the material looks like it's a little bit feathery, like as if there were some crystals that dissolved out. So this is gout. Palisade of histiocytes surrounding feathery material. The next slide also looks like there's palisading of histiocytes. So here's our palisade of histiocytes around very dark reddish material, so dark pink to dark red. So this is actually a rheumatoid nodule. And so we'll contrast that a little bit later with that light mucinous material that you saw. So moving on now to another slide. We have a split right here within the epidermis, and it does look like it's right above the basal layer with most of the epidermis intact, and there's some serum and some inflammation here. And when we look even a little bit closer as we zoom in, we see that there is sort of this tombstone layer or intact basal cells with splitting of the epidermis off right above it without much acantholysis or separation of cells in the epidermis above that. So this is compatible with pemphigus vulgaris. Coming to this slide here, we have a crateriform or cup-shaped lesion with keratin in the center, and that lesion is surrounded by enlarged keratinocytes. And so the keratinocytes have nuclei that do not appear particularly atypical, and they have a lot of pink cytoplasm. When we look at the border of the lesion, there's not too much atypia, maybe a little bit of pleomorphism here and there, but there is not any prominent mitotic activity. There is elastic fiber trapping within the epithelium. And sometimes you can see eosinophils or neutrophilic abscesses and some degree of fibrosis within the dermis. And so this is a keratoacanthoma. Some consider keratoacanthoma to be a variant of squamous cell carcinoma. For such a well-circumscribed lesion such as this, and it looks like the whole thing is out, I think to say consistent with keratoacanthoma or squamous cell carcinoma, common keratoacanthoma type, margins not involved would be sufficient. This next slide looks like there's a relatively well-circumscribed tumor within this dermis. It looks like the cells are large and there's not quite maturation of cells, meaning the cells don't look like they become particularly small as it descends into the dermis, although you could argue that the cells are a little bit larger here and a little bit smaller here. But for the most part, there are cells that are quite dark. So there's pleomorphism, there's variation in nuclear size and shape. And as we look a little closer even, we see that a lot of these cells have fairly prominent nucleoli. And again, there's pleomorphism with variation of cell to cell. And there is a little bit of pigment here and there suggesting that it's a melanocytic lesion. And with this degree of pleomorphism and without much epidermal involvement at all, if we zoom out, we can check that epidermis. This would be compatible, especially, I think in real life, I would stain this and confirm that it's S100 positive and maybe SOX10 or melanase, some other melanocytic stains positive, but we see there's not any involvement really of the epidermis. And so this would be compatible, and here's some of that melanin pigment, compatible with a metastatic melanoma. This next slide is quite interesting. There's some cartilage right here, and there's some inflammation going on here. And as we zoom in, we can see that there's a lot of clearish cells within here with mixed inflammation. And as we come in a little bit closer, a lot of these clear cells appear to have some kind of sort of granular material, not quite granular, but maybe just sort of dusty or just kind of, fragmented cytoplasm. And this kind of cytoplasm is compatible with rhinoscleroma. So this mixed inflammation with these histiocytes with this sort of cytoplasm that's falling apart. There often are red cells interspersed. And so you could definitely think about a renal cell carcinoma, a metastatic renal cell carcinoma in your differential here. But this mixed inflammation with neutrophils and some lymphocytes and these histiocytes with this kind of grainy cytoplasm is pretty characteristic of rhinoscleroma. This next slide here, we have a tumor that seems to be filling the dermis and extending in this honeycomb pattern into the fat. So right away, we can appreciate that at low power. And as we zoom in, we do see this even better, that there are cells that are interspersing themselves in between the fat cells, so a nice honeycomb pattern. And interestingly, I always find this fascinating about this tumor, that when we look at the cells, they look actually fairly bland. And this is very characteristic of this entity, which is dermatofibrosarcoma protuberans. So these spindle cells, they look like they're sort of cartwheeling or whirling around and honeycombing through the fat. And it often does extend from the dermis down into the fat, as we saw at low power here. Here's another slide, and there's a little bit of acanthosis. Sometimes there's even more pseudoepitheliomatous hyperplasia for this type of lesion. And we get the sense of neutrophils as well as histiocytes at low power. So this is an infectious pattern. And when we zoom in, we do see giant cells, we see neutrophils. And so we are very concerned that it's an infection. And I did find it hard to find the organisms as I scanned around. So you may have had the same problem. But when I did look around, I did finally see, and I believe it's right here if I zoom in just a little bit more, there are some organisms that looked like yeast forms. I just looked to find them. And here it is right here. So here, there's this thick-walled yeast form. I'm just gonna zoom in a little bit. And as we get closer in, we can even see that the wall is quite thick. And so this is blastomycosis. Here is, I believe, the last slide that I'm going to show you guys. And if I just turn it around, we can notice right away that this looks like acral skin with quite a thick stratum corneum. So here's a thick stratum corneum with a stratum lucidum, suggesting it's acral. And it's this nice polypoid shape, so we can imagine it was this little papule that stuck out. And very importantly, just look right there in the dermis, and we can see all of these structures that look like nerves, nerve bundles. So normal nerve bundles, but way too many of them with sort of tapered and squiggly nuclei and light pink around those squiggly nuclei. So this is an accessory digit. And so sorry, I lied, that wasn't the last slide. So here's another slide, and if I zoom in, we can see that the epidermis is falling apart. And it seems to be not just right above the basal layer, as we saw with pemphigus vulgaris, but the stratum spinosum also has falling apart of cells, breaking apart of cells from cell to cell. So this is what we call acantholysis. And so the diagnosis for this one is Haley-Haley disease. Here's that accessory digit that we just ended with. And these are screenshots from Path Presenter. And we can see that there are these little nerves in this polypoid shape with the stratum lucidum and the thickened stratum corneum of acral skin. So here's another lesion that is usually on acral skin, so thick stratum corneum again, but when we look in the dermis of this polypoid shape, instead of the nerve bundles, which we see here, we just have collagen that's sort of vertically streaking up. So this is an acquired digital fibrokeratoma. We can compare blastomycosis and chromoblastomycosis, which I think can look a little bit similar, but obviously chromoblastomycosis, the medlar bodies are pigmented. The three palisading reactions that we looked at, we had granuloma annulare, gout, and rheumatoid nodule, and side by side, we can really appreciate that loose light blue mucin surrounded by the palisade for granuloma annulare and the perivascular lymphocytes. For gout, not much of a histiocytic layer that palisades around this feathery light pink material, and then rheumatoid nodule, the palisades around that bright pink fibrinous red material. Pemphigus vulgaris and Haley-Haley, this is something that I always found difficult when I was a resident. But here's that tombstone layer with an intact epidermis above and maybe some necrosis right in there. But Haley-Haley, not just some tombstoning, but also acantholysis through much of the epidermis. And just contrasting leiomyoma and leiomyosarcoma. So this is a typical smooth muscle cell with a cigar-shaped nucleus and a lot of cytoplasm extending outward from either side. Here are smooth muscle cells cut in cross-section with that nice perinuclear vacuole and a round nucleus because this nucleus is just cut in cross-section. So fascicles of cells. So leiomyosarcoma retains those fascicles and the perinuclear vacuoles, but you can see the cellularity is much increased. And rather than these nice cigar shapes, there are some cigar shapes still, but they're pleomorphic with a lot of hyperchromasia and some degree of variation in cell size. And then dermatofibroma compared with DFSP or dermatofibrosarcoma protuberans. The cells in DFSP, like I mentioned before, are usually quite bland. They're relatively small, and they don't particularly look atypical or malignant in terms of the cells themselves, but this honeycomb pattern through the fat, this infiltrative pattern, I think is what really helps to clue into this diagnosis. Dermatofibroma, by contrast, can have sometimes actually wildly atypical cells, and we call them monster cells. when they're quite prominent and multinucleated. But for dermatofibromas with smaller cells, they whorl and spindle around collagen. So this is called collagen entrapment, and it hardly ever really honeycombs into the fat in the way that dermatofibrosarcoma protuberans does. And the last thing I just want to go over is our giant cell tumor of tendon sheaths. So we have these osteoclast-like giant cells with the nuclei resembling the nuclei of the histiocytes around. And so just to go over the different type of giant cells that we may see, these are not pathognomonic for anything, but I think they are kind of sometimes characteristics of foreign body giant cells with the nuclei just scattered within the cell. Teuton giant cells with that wreath shape with the pink cytoplasm inside and then the foamy cytoplasm outside. Here's our osteoclastic giant cells that we just saw in giant cell tumor of tendon sheath. Oncocytic type giant cells with bright pink two-tone cytoplasm, which can be seen in reticular histiocytoma or multicentric reticular histiocytosis. Here are some atypical multinucleate cells, which we could see in atypical fibroxanthoma or an undifferentiated sarcoma. And here are Langhans giant cells, a sort of horseshoe-shaped arrangement of nuclei, which can be sometimes seen in sarcoidosis. So thank you.